Hello, I am Barry, and welcome to Fertility Fact or Fiction, where we review everything new and exciting questions. So we are here to bust through the fertility myths, on the things they can do to help themselves make their journey a little bit cheaper. I am here with my team, or I guess pretty soon I'm going to have a team. That's a nice introduction. So Ajay's group, he does all of our social. For joining us tonight, topics out. I thought that we online search of a topic, if you guys could figure out why it is in understanding it not, and I intentionally pick something controversial just to show you how and some of these on a daily basis. So when you go online, it says, hey, if you take this, it'll help you. You have to take all of that with a lot that goes into these decisions, knowledge you need to have to be able to probably telling you. And even if someone study, you need to then understand if that's affected or not. So as an example, when I was TRE, which is the European Society of Hormonology, in July, I had in Italy for that conference with most of my team. Many different sessions where the thing that kept dawning on me was, hey, sense the next study, that study, they had different comparisons, and they hadn't necessarily, or they didn't explain to the decisions. And without knowing analyzed studies, you could walk away saying, duosin is the worst thing ever, and you would. So what we decided to do. We're just gonna. It's on. Oh, can you hear me better now? They should be able to hear us better now. Whoops. Okay. So what we decided to do was, can they hear us better now? They should be able to. Yes. Okay, sorry about that, guys. So what we decided to do is do a live search with you guys on something kind of controversial and exciting to show you how complicated it is to learn this stuff and to understand it. So I have not prepped for this other than to kind of pick my topic. So we're going to do it together. We're going to learn it together, and we'll go through what we can go through. It would probably take hours to explain all of the nuances and details, but we're going to give it a shot. So what's the most controversial topic in all of fertility? That would be, does the endometrial scratch improve your chances of success? So we're going to type in endometrial biopsy. We could type in scratch, but it's technically a biopsy. And IVF. And we're going to hit return. And we're on PubMed. PubMed is the National Institute of Health's and National Library of Medicine's medical search engine. If it's published out there, it's in PubMed, generally speaking. So if you look on, if you look on the left all along here, usually you want to make sure that they have an abstract, because if they don't, it's kind of hard to figure out what's going on. Free full text is great, but shouldn't limit us necessarily. Full text is certainly helpful. And then you got to pick what kind of trial. So let's just go through this. Books and documents, useless because they're always out of date. Clinical trial, sure, but what kind of clinical trial? Meta-analysis is when they take all of the available studies and they pile them in together. So if you're studying something with low numbers in individual studies, but there's 5 studies on it, you can merge them together and get one big study, which should give you a better answer. Randomized controlled trial, this is level A evidence. So this is the best kind of trial that we have. Reviews are decent. Systematic reviews are more formalized reviews, where they actually have a policy and procedure for how you include the studies that are being reviewed. And they're not completely dissimilar to a meta-analysis. Frequently, they're put in together. You get a systematic review and meta-analysis. Publication date, if it's more than 10 years, that's probably starting to get old, but some things won't have that many studies. 5 years and 1 year is certainly reasonable. 1 year in something like this, you're not going to find that much stuff. So you can see right off the bat that a bunch of the stuff we're looking at has nothing to do with what we want. So it's not about the endometrial scratch. This is conventional and modern markers of endometrial receptivity, analysis of serum and endometrial progesterone and determining endometrial receptivity. This is all endometrial receptivity. So what do we want to do? We want to try randomized controlled trial. So now you're going to see some stuff that's going to help you. So the first study says endometrial scratching in women with one failed IVF ICSI cycle, outcomes of a randomized controlled trial. This one's about endometrial hyperplasia, so we don't care too much about that. You go down a little lower, this is endometrial receptivity. We got another one, endometrial scratching for women with previous IVF failure, undergoing IVF treatment, endometrial scratching in women with implantation failure after a first. This is the initial proposal for the study that I showed you earlier up there. A randomized trial of endometrial scratching before IVF, local endometrial injury. So as you can see, we're bringing up lots and lots of studies. And just to kind of put it into perspective, there are 45 studies that the system has highlighted here for us. So let's just take a quick look at some of these, okay? So here is the result of the first one, and we're going to actually pull up the article for you. We'll pull it into PDF. Okay, and then hopefully I can expand this so that it fills the screen. Can you see that pretty clear? Okay, so relatively new article, December 8th, 2020. So, last few years, published in a top class journal for fertility. This is the highest ranked fertility journal in the world. Endometrial scratching in women with one failed IVF ICSI cycle, outcomes of a randomized controlled trial. And of course, they called it SCRATCH, which is quite funny. Okay, so let's look at their study question. Does endometrial scratching in women with one failed IVF ICSI treatment affect the chance of a live birth of the subsequent fresh IVF ICSI cycle? So these are all people that failed an entire cycle initially. They're coming back for a second cycle, and they're doing IVF and ICSI, and then they're doing the endometrial biopsy. So the study design, non-blinded randomized controlled trial. So first problem is that not everybody got the same treatment. Half the group did not get a biopsy, half the group did get a biopsy. The problem is you can't do an endometrial biopsy without doing an endometrial biopsy. So arguably you could maybe pass some kind of catheter in there to get it as close as possible to being a scratch without actually scratching, or put in the catheter without actually doing the biopsy part of it, which is reasonable as well. So they didn't match them exactly. It was unblinded. People knew what they were getting. It took place in 8 academic and 24 general hospitals, so very large thing. And they looked at 12-month ongoing pregnancy rates leading to live birth. They actually got a huge number of patients. So in total, there were 933 participants out of 1,065. So that's really great, high participation rate. So after the fresh transfer, 4.6% more live births were observed in the scratch compared to the control group. And then they say 110 out of 465 or 88 out of 461. So your relative risk, 24% increase. But look at the confidence interval. It does not stay on either side of one, and it has to in order for this to be statistically significant. So in other words, there actually was no difference. So if you read this and you didn't know that you have to make sure that the confidence interval is on one side of the number one, either below it or above it for both numbers, you wouldn't understand that the actual conclusion from this study is wrong. So they didn't have 4.6% more live births. They had the same number of live births because the confidence interval crosses 1. And then they say these data are consistent with the true difference of between minus 0.7 and plus 9.9%, indicating that while the largest proportion of the 95% confidence interval is positive, scratching could have no or even a small negative effect. So they're admitting that they don't know for sure. Biochemical pregnancy loss and miscarriage rate did not differ between the two groups, so same percentages. And after 12 months of follow-up, 5.1% more live births were observed in the scratch group, of which the true difference most likely lies between, again, minus 1.2 and positive 11.4%. So because it crosses 1, this isn't actually showing any significance. So you look at this and initially you think, oh, if you're not reading it properly, oh, they said 4.6% more live births, so everybody's going to think, I want to scratch. But if you understand how to read this study, you'll recognize that actually it doesn't do anything for you. So now we're going to go back and we're going to see what the next one looks like. So now we say, well, maybe this one doesn't say what I want it to say. I want to find one that says that something actually worked.
Can you check your audio one more time? I'm seeing it scratch it again.
Really? It shouldn't be defaulting. It keeps defaulting.
It does.
Okay, let's try that.
Okay.
I'll just exit over to this one. See how the audio is there. Okay, so let's look at the next study, which is endometrial scratching for women with previous IVF failure undergoing IVF treatment. So we're going to look at the article again. Where is my full article? Hopefully right there. Oh, this one wants us to purchase. Okay, so sorry about that. This one isn't available in a PDF, but this one says randomized controlled trial, 387 women with previous IVF failure, divided into two groups. 193 got the biopsy procedure twice, and group B were subjected to a placebo procedure. So they did actually pass a catheter in. They just didn't take anything out. No actual scratching. So no difference in live birth rates. However, regression analysis revealed that endometrial scratching was an independent predictor of live birth in the subgroup of women with 2 or more previous failures after control of other independent predictors. And it was quite significant, a 240% increase that was highly significant. So they said it doesn't improve live birth rates overall, but maybe for women who've had 2 or more previous IVF failures, this might be helpful. Now, I have to go and purchase the article if we're going to read the rest of it. But the reality is that you'd have to go through this now and see exactly what the details were. Did the other groups that had failed twice before get additional treatments, or was the biopsy the only treatment that they were allocated? Were they on steroids? Were they on heparin? Were they getting intralipids? What were the differences between the two groups? Why did they fail before? Were there age differences and so on? Okay, so we're going to exit out of this one. We're going to go back. Is the sound okay now?
Mm-hmm.
Okay, so we're going to go down to this one. And this one I can get the full article on. Okay, so same thing. We'll blow this up for you guys so you can see it clearly. So European Journal of Obstetrics and Gynecology and Reproductive Biology, certainly not the highest ranked journal out there, but a good journal nevertheless. They have good publications here. And it's a well-recognized, peer-reviewed manuscript. Okay, so what did they do? Evaluate the effectiveness of local endometrial injury in women undergoing IVF with at least one previous unsuccessful attempt. So similar to the other one. Randomized controlled trial in group A, the Pipel group, women got the biopsy twice in the luteal phase, which is the way you're supposed to do it. In the cycle prior to IVF, in group B, women got no intervention. So again, the women who had an intervention will think that they've had something done that helps them versus the group that doesn't. And there is an impact of a placebo effect. So this is not a well-done study because they did not have
a proper control arm. And again, you would need to know that reading this. Maybe you know that because you know how to analyze the study, but if you don't, you could take away the wrong message from this depending on what it shows. So 111 women were included in the study, 55 in the Pipel group, 56 in the controls. Baseline characteristics the same. It should be that way in any randomized controlled trial. Clinical pregnancy rates were not significantly different, 34 versus 27%. Confidence interval crosses 1. The live birth rate, same. The confidence interval crosses 1. Multiple pregnancy is same. Miscarriage the same. And preterm delivery rates. Also, all of these things, same. You're not seeing any difference. So you read this one, you say, well, okay, it wasn't the greatest study ever, but again, these guys are showing no difference. So now finally, we realize that we're down at the bottom and we turn the page and now we got a bunch more of these studies, right? So follicular phase, endometrial scratching, a truncated trial. In this one, we'll pull that one up for you also. So far everybody has said, don't bother, it's not gonna work. And now we're gonna go to, whoops. Okay, so now we're going to check this one out. And it says, does intentional injury during the follicular phase, remember everybody before did luteal phase. And here they say clinical pregnancy rate did not vary between the endometrial injury and the control group, but the trial was underpowered due to early termination because of a higher clinical miscarriage rate observed in the endometrial arm after a pre-specified interim analysis. So what that means is, halfway through the study, they stopped the study because the group that was getting the scratch had a higher miscarriage rate. Now, the important thing here is, obviously, these are all people undergoing fresh embryo transfers. And the problem with that is we're not doing a lot of fresh embryo transfers anymore. So this isn't, again, all that applicable to someone unless you're actually going to do a fresh embryo transfer. The data here may not help you because it doesn't apply. So you have to know how to not only read these studies, analyze these studies, but then look at them in terms of, how does it apply to you? So now what we're going to do is say, well, there's a lot of studies here, 45, like we said. Let's skip randomized controlled trials. What does the meta-analysis say? Let's get somebody else to do all the work for us. Let's take a look at the studies where somebody else has piled it all together. So the Cochrane database is a great opportunity for that because they have mishmash meta-analyses of pretty much every topic in any field of medicine that you want, and they're great for OB and GYN. Okay, so back in 2021, they did an endometrial scratch meta-analysis. So what did they say? So they said that implantation of an embryo within the endometrial cavity is a critical step. We all know that. Previous research has suggested that endometrial injury may help. So let's assess that. And so they did this study where they piled in all of the different data points. So you look down here to main results. Endometrial injury versus control, no procedure or a sham procedure. A total of 37 studies with 8,786 women were included. Most studies performed endometrial injury by Pipel in the luteal phase. So again, it's saying most, but not all, which means you're getting a mishmash of people that did it at different times. So maybe not necessarily the best ones to pool together. They restricted it to studies that were at low risk of bias, which is important for good quality data. And that left you with 8 studies. So the effect of endometrial on live birth is unclear, as the result is consistent with no effect or a small reduction or an improvement. So these guys basically said what one of those earlier studies said, nothing about the subgroup. They're just saying it doesn't really look like it's that promising yet, because you could be less chance of success, same chance of success, or maybe more. We don't know. So basically they said if a live birth is usually 27%, this could be anywhere from less than 27% up to 32%. Similarly, for clinical pregnancy rate, it's also unclear. So if it was 32% for clinical pregnancy rate, now it's 31 to 37%. So you're still not seeing anything, very helpful here. So this also doesn't show us anything. The results suggested that if the chance of miscarriage with IVF is 6%, then when you did the endometrial injury, it would be between 4.2 and 6.8. So even for the miscarriage, it's still showing us the same thing. You could maybe be beneficial, maybe not beneficial. And then they looked at higher versus lower degree of injury. Only one small study was included in this comparison, which compared two different instruments, a pipette and something called a Shepherd catheter. They excluded this one. So basically they conclude, we can't tell. It's unclear. So then you look and you go, well, this doesn't help me. Let's go find another meta-analysis. So let's find another one. So here's another meta-analysis, also in Human Reproduction Update, great journal. Let's take a look at this one. And this is 2019. So this one, they did something similar, but notice here, they've now got 10 studies and 1,260 patients. So here they said overall, when studying the effect of endometrial injury on clinical pregnancy rates and live birth rates, higher rates were shown in the endometrial injury group. However, it did not significantly improve clinical pregnancy rate and live birth rate when considering subgroup analyses of studies including patients with 2 or more failed IVF cycles. So they're saying here, overall in their study, there was an improvement. But if you look at the people that have failed twice before, which that other study individually showed was beneficial, here they're saying it actually showed no benefit. So like you read this stuff and it leaves you blisteringly confused. My rationale for taking you guys through all of this, audio again, really?
That's what they're saying.
This is crazy. I don't know why it keeps flipping back. No, it's on the Brio.
It's not real?
Yeah.
Okay.
I can exit out of that though. We can switch if you want. Go back to, you want to set up the camera? I'm gonna switch or you don't think it'll work?
No, just
Okay, it's on, I shut off echo cancellation. I don't know. But it's on the Brio. So the point of all of this is to demonstrate to you guys that it is not easy to figure this stuff out by reading. The worst is when you're just reading some lunatic on social media who has a completely bizarre opinion and makes no sense whatsoever, like that post I made fun of, where she's saying that there's all these benefits to eating raw placenta. There are 0 benefits to eating raw placenta. 0, it's being studied. So for people that are doing their own homework, I encourage it. I love having educated patients. But understand that unless you actually have the ability to know how to do the research and then analyze the individual studies, and if you're looking at a meta-analysis, analyze the individual studies that went into the meta-analysis and how they conducted the meta-analysis, you're not qualified to come out of that saying, I know what to do now. And that's our role, is to study this stuff for you and come up with an informed opinion after being trained to do all of that. Importantly, your doctor should be doing this for you. Not every doctor does, and I totally acknowledge that, and that's why many of the patients advocate for themselves, but you shouldn't have to. So it wasn't quite a fact or fiction tonight, but I guess, is it a fact or fiction that you can do your own research? You can, but it's challenging and you got to know what you're doing. Okay, so now I'm going to stop screen sharing, or am I
You don't
not?
have to worry about it. I took care of it. I shut it off.
So are we connected to you now?
Yeah, you're good.
But the camera's not connected to your, do you
Yeah,
want to just connect the camera to you?
No, I don't want to unplug anything. Just leave it
Okay.
offline.
How's the sound?
No complaints as of this moment.
Okay, fire away.
So, first comment on Instagram that I saw that I loved. Big love. Hi, Batman and Batman. That was great.
You can't do that to me when I'm
I
sipping
said,
tea.
in my mind, I said to myself, this is the wrong time for the guy to be sipping on his tea. I didn't believe that.
That's awesome. I like that one. That's good. Batman and Batman. Yeah.
How long before an egg retrieval do you recommend getting a COVID booster and flu vaccine?
Doesn't matter. So before the COVID booster, you can do it whenever you want. Now, later, it makes no difference. FET, you got to wait, but don't worry about the COVID booster. You're fine. How's the sound?
So far, so good. No one's
Okay.
complaining this yet. Yes. Is blastocyst hatching helpful after throwing?
After throwing? Thawing.
Must be
They must
thawing.
have meant
They
thawing.
must have meant thawing.
Yeah, It depends on who you ask, and the latest guideline actually says it isn't, but we do it, and I believe that it helps. So we tend to do hatching, and we do it after the thaw. Some people do it before the thaw, like before the freeze. We do it after. So yeah, we do it, and I believe in it. I mean, helping the embryo to break out of its shell should be helpful. It just technically makes sense.
What protocol for IVF would you recommend for a woman in her 30s with stage 4 endometriosis, excised, and a low AMH?
Depends on how low the AMH is. I would say either a mini stim or a medium stim. We would use a microdose flare protocol. We would use letrozole. I'd probably try to give you some DHEA ahead of time. Arguably, you could use Vizan for 3 months if you're in Canada prior to starting the IVF, because that has been shown to be beneficial. I would never do a fresh transfer. I would wait, and then we would put you on Lupron and letrozole for 3 months, and then use a letrozole primed cycle for your FET. So that's what we would do. Lots of supplements to treat the endo.
High, multiple exclamation marks.
Hi.
Question.
Yeah.
I thought 10 m sperm per milliliter was a lot, but apparently that's not the case. Why do I need so many sperm?
Because we're lazy. You need a lot of sperm because the sperm actually have quite a challenging pathway to get to the egg. They've got to avoid gajillions of immune cells, some rough territory getting to the egg. They're trying to crowd each other out. It's a big battle scene. So they need to get to the race. And then even when they get there, the egg has to kind of pick the sperm and the sperm has to pick the egg. So lots of them can bind, but only one actually manages to be selected and get through. So you need millions in order for that process to actually function properly.
Dr. Victory and Tarek.
Okay. No Batman and Batman.
It's all wrong. Dr. Victory and T.
Yeah. Okay.
I was so excited that my period came back after taking Prometrum, and I went for baseline today, and my progesterone level is super high.
Okay.
And I've been bleeding for 3 days.
Okay.
Why?
You may have released an egg recently, and so the timing of your progesterone withdrawal was off. If you had released an egg on your own, so that's a possibility. Or there's just some residual progesterone hanging around inside you. It should settle, just give it time. But keep in mind that progesterone withdrawal bleed is not ovulation, and ovulating is important for your general well-being. I mean, getting an anovulatory bleed with progesterone is also important, but that's important.
Dr. Bean Tarek? That's actually what it says this time.
Okay.
Can I eat raw turmeric while on Lupron Depot, or should I introduce towards the end of Lupron?
I don't think there's any study out there talking about the relationship between turmeric and whether it's the desiccated kind or it's the raw kind and Lupron. So I would say there's no data on that, and I don't think it would be a problem. So I go ahead and use it simultaneously.
That's what I also thought.
That's what you thought too.
How does a Lupron Depot letrozole protocol look like?
3 months of Lupron, so 11.25 intramuscular injection, and then 5 milligrams of letrozole. Extend it for 5 days past the 12 weeks. So take the letrozole for 5 days. Stop. You should start growing an egg, and then you fire off into your cycle. Monitor your lining thickness, and when it's thick enough, start the progesterone, and away you go. Or you could trigger and do the start of the progesterone. It's up to you.
I'm going to get one from
the previous questions. We had loads of those.
Yeah. In the meantime, what supplements to take while on Lupron Depot? Vitamin C, D, E, magnesium, calcium, NAC, CoQ10, prenatal, etc.
Yeah, all of those are good. So curcumin, which is the turmeric, resveratrol, NAC, and coenzyme Q10 are the 4 big ones for endo cases. So all of those would be reasonable to choose. Yeah.
No question. Just thank you for taking the time to always answer our questions.
Oh, my pleasure. Thank you for watching, and we love you guys. So this is amazing.
Hello, T and Dr. V. On a pre-question.
Okay.
I think that's kind of special.
Okay.
Should I hold off on getting a pap smear the same month as a FET?
No, your pap smear has absolutely zero bearing on your FET. Nothing would happen.
What is an optimal time to do a transfer after first baby born by C-section?
Well, you want to breastfeed for a minimum of 6 months. If you're thinking about doing vaginal birth after a cesarean, you need a minimum of 15 months from delivery till pregnancy, minimum. If you're thinking of just having another C-section, 6 months to a year to breastfeed and then get pregnant again.
Do you recommend uterine HCG or Neupogen wash for recurrent implantation failure?
Yeah, we do. I mean, both of those have evidence for success. We use both, and it does seem to work fairly well. So, yeah, I support both of those. Both of them have evidence to support their use. So, yeah, we use HCG, we use Neupogen. They're reasonable choices.
I have adenomyosis and endometriosis since 10 years ago.
Okay.
Is there any way to deal with it?
Lupron, letrozole, those are the two big ones. Surgery, if it's really bad. Vizan will work, or Alyssa can work. So there's a bunch of different options for you for sure. Yeah, I mean, there's lots of things you can use that will help you.
38,
Okay.
AMH.2, FSH normal,
Okay.
AFC between 5 and 7,
Okay.
mini IVF or conventional for my first cycle.
Oh, it's tough. I'd probably do like an in-between. I wouldn't go like full bore heavy doses, but I probably wouldn't do mini either. I'd probably try and maximize the chances of getting those 5 to 7. So maybe a total dosage of 300. Mini would be 150 and less. I'd probably go up to 300. So maybe 150 going left, 150 Menopur. Use letrozole, use a microdose flare. That would all be a reasonable approach to things. DHEA, human growth hormone, we use a lot of that.
AMH 2.2, 721 to 1.3 to over 22.
Those are the dates. So she went down from 2.2 to 1.2
to 0.94 August 22nd.
Okay.
Age 37, 38. Is the drop normal? What should I check?
If you're talking about picomoles per liter, because you haven't given us the units there, has she? Then that's normal because you were pretty much almost menopausal at the beginning and now it's just more menopausal. If you are not using picomoles, you're using nanograms, that's a big drop, and I want to know more about you, like your thyroid state, your vitamin D levels, things that can interfere with your AMH. So your stress levels, what you've done in the meantime for your fertility. So yeah, I would get that checked out. So if you're nanograms per mil, that would be abnormal. If you're picomoles per liter, it just means your ovary was very weak to begin with, and now it's become weaker, which over that time period we would expect. Bet you didn't know that one.
I didn't. Hey, is it wrong for me to say that sometimes you say something on the show I never knew about?
No, that's okay.
That's okay, right?
As long as we keep our boundary lines clear.
Although some questions I kind of feel I can do it. Only because I heard you say it, not because of my own.
Let's get enough thumbs up to see if we can sit Tarek here and let him answer the questions. I'll ask you and see what you say.
You'd be surprised, I think.
Yeah, we'd have to put a mask on you though.
We did pretty good. Dr. T and V.
Dr. TFB.
Let's get like 50 questions to read that one. I know it's patient specific,
Priceless.
but what is your DOR IVF protocol? My AMH is 0.24 nanograms per mil.
So that's very low. I'd probably be inclined to consider doing just a straightforward, natural cycle stim for you, or maybe a mini stim. Cases like that where you're only going to make 1 or 2 eggs, you should just make 1 or 2 eggs. it doesn't matter what we do, you're not going to get a big difference out of it. So those are the cases where less is more, because pounding you with the heavy drugs is anxiety provoking, expensive, probably not great for egg quality. And then you only end up getting 2 eggs anyways. So it's just easier to go and get one, like stop the meds and just do a natural cycle IVF or take mini stim and get 1 or 2 eggs.
Follow up from DOR question.
Yeah.
I'm 31
Yeah.
and otherwise healthy.
Okay.
1 failed IVF. Eggs were granular and dark pitted.
Ah.
That's the same lady that asked previously about Dr. T and V.
Yeah, I mean, you want to do everything you can to optimize your egg quality. So naturopath, acupuncture, vitamin levels, coenzyme Q10, no smoking, no drinking, no drug use. Eat a really healthy diet like the Mediterranean diet. Make sure your weight is low. All these things will be beneficial for you. So those are the things I would look at. Yeah.
Greetings, doctor, with a picture of a television.
Oh, very cool.
See what they did there?
They're watching us.
They're watching us. That's hard. Question regarding trauma to a newborn baby as a result of surrogacy.
Oh, I know who's asking that question. Hi, V. So, yeah, there's no evidence that I'm aware of anywhere that says that babies are traumatized by being born from a surrogate mother and then being given to another parent. That's like saying everyone in the world who has ever adopted grew up being abnormal, and that's simply not the case. So I don't believe that that's an issue at all. And there's certainly no evidence, to the best of my knowledge, to suggest that children that are born to surrogates or are adopted by others have a different life than anyone else does. So I don't believe that that is something that's important.
Do you do ovarian PRP?
We're trying to do ovarian PRP. I'm not convinced it works, but I want to trial it. So yes, we are going to have that set up at some point in the near future.
Why induction in 39 weeks is more beneficial than waiting for a labor to start naturally?
So we have a whole video on that. I can probably pull up the video.
Yeah, probably good.
I probably could. Let's go show you the video. Let me go here. Go to Dr. Victory. Okay, so if you go here, guys, and you go down to, actually it was up here somewhere, right here. First line and the very last video, we have a whole video on inducing pregnancy and why it's beneficial. So go check out that video, because that tells you everything. But the bottom line is it's safer for baby, it's safer for the mom, the outcomes are better, and the satisfaction rates are the same. So it's a total no-brainer as far as we're concerned.
Does endometriosis affect fertility or reoccurring miscarriages?
It definitely affects fertility. It's questionable about the miscarriage part of things. Some people believe that it does increase the chances of miscarriage. Other people believe that it does not. So we're not sure about miscarriage, but it definitely impacts fertility. There's no question on that. So if you have endo, it's really good to get that treated as part of your fertility therapy or in line with your fertility therapy.
Do you recommend the Omicron booster in pregnancy?
Yeah, absolutely. If you're not immune to Omicron, get immune to Omicron. So that's new and it's just coming out, but yeah, you should get on that.
1 MC at 10 weeks.
Yeah.
Then a blooded ovum, 35 years old.
Okay.
Time to come see you?
35 with 2 miscarriages in a row? Yeah, I would. That's the definition now that most people are using for recurrent pregnancy loss, is 2 miscarriages in a row. So yeah, I would come and see us, make sure everything's okay. Dot all the I's, cross all the T's, make sure that it's not going to happen to you again.
Secret sauce question.
Secret sauce question.
What is your typical FET protocol for someone with adenomyosis?
So you want a low estrogen FET protocol. And again, you probably want 3 months of Lupron and letrozole first. So 3 months of Lupron and letrozole, then extend your letrozole for 5 extra days. Hope that an egg starts to grow on its own. If it doesn't, you want to give like the smallest amount of estrogen possible, like literally 1 milligram, and see if that thickens the lining enough. The minute you hit about 8-9 millimeters, start your progesterone, vaginal and injectable. Get it to the right level, continue it for the right number of days. Usually 5 days if you're doing a day 5 embryo, 6 days if you're doing a day 6, and then do the transfer. Lots of supplements. You need antibiotics and then probiotics. Make sure you're on all the right supplements. So melatonin, NAC, and coenzyme Q10, curcumin, and resveratrol. That would give you your best chance overall.
Hi.
Hi.
Does positive BCL6 on receptiva mean that I have endo?
No, that's been proven to be non-predictive. So there was a study before, and I think we reviewed it on the show actually, demonstrating that BCL6 is not useful. And then there was another study that came out recently, about 6 weeks ago, I want to say, where again they demonstrated that the BCL6 thing is just useless for predicting fertility or endo. So no, it does not predict endo. Ignore it. It's not helpful.
Dr. V and Tarek, what you do is amazing.
Aw, thank you. We love you guys. It's a fun show. I get to sit in my office with Tarek. We always get dinner. We have a good time laughing. We won't talk about what we laugh at.
Something to invest
Yeah.
in the secret.
Yeah. Locker room discussions are going to stay locker room. Yeah.
Do you believe in doing KIR exams for all single women or lesbians using a sperm bank?
No, not always.
Good enough for me.
Yeah, sometimes, but not always. Not everybody needs that.
How long before an egg retrieval to get the flu shot or COVID vaccine booster?
Egg retrieval is not related to vaccines or boosters. Your embryo transfer is. You can do your egg retrieval whenever you want in relation to a COVID booster or a flu shot vaccine. So that won't impact it. Would I do it right at the same time? No, but as long as it's off by like a week or something, you're fine. Yeah.
What should I tell my doc? These are my favorite questions.
Doc, D-O-C.
Yeah.
Not the dog.
No, doc.
The doc.
There was a G in there?
Okay.
I apologize.
No, I wasn't sure. I was like, I don't know what to tell your dog.
Yeah, so what should I tell him?
Okay.
If he insists
Yeah.
on BCP to start FET protocol, I have a thin lining.
Tell him he's wrong and that you don't want to do that. I mean, that doesn't make sense. The BCP will suppress your lining, and the only reason to put someone on birth control prior to an FET is for timing. So don't do that. That doesn't make sense.
From Europe.
From Europe.
That's what I got.
Awesome.
Is DHEA 25 grams only 9 days before protocol starts helping? 40 years old, slightly low testosterone, worried, half about side effects.
I cheated and I responded to her privately.
Super cheating.
Yeah, super cheating. I'm sorry. She said she didn't know how to watch the show because it's like 2 a.m. Right? So if you're watching from Europe, our show does play on YouTube afterwards. And the answer is 9 days of DHEA is not nearly long enough. You need at least 2 to 3 months of DHEA to get the antral follicles to be exposed so that they're going to have what they need in order to develop into good follicles when they're actually ready. The side effects are minimal at the doses we use. You might get a little bit of acne and hair growth. That's about it. There really is no other side effect. Yeah, so I would go ahead and use it. But not for 9 days. That's useless. You're not going to get any benefit from that.
There's a question here that I happen to notice. Starts off with all the general pleasantries.
Yeah.
And it says, hi, Dr. V.
Okay.
And T.
Okay.
See if Dr. T can answer this one.
Okay.
Funny face smiling.
All right.
Right?
All right.
What is the earliest you can see a heartbeat on an ultrasound?
And your answer, Dr. T?
You know, I think I've seen you answer a similar type question.
Okay.
My guess,
Yeah.
not based on going to medical school,
Okay.
just to put it all in
So you're
context.
saying you never went to medical school?
I want everyone to know
Okay.
I didn't go to medical school, but
All
I
right.
think by attending Fact or Fiction, I believe somewhere the earliest 5 to 6 weeks, maybe
Can you be more specific?
5.5. I don't know.
Yeah. So with a super, super strong, very sophisticated ultrasound, thin patient, easy to see, good position of the uterus, 5 weeks and 5 days is the earliest you'll see a heartbeat.
Give me my diploma.
I know
man.
you deserve a. We got to come up with some kind of prize for Tari. I will give him.
The prize is learning from you.
I will give him my post-it note doctor's scrubs booklet thing here.
No. This is knowledge from the show.
Here you go, buddy. That's for you.
We all benefit from the show. We all
Yeah.
benefit from the show.
Yeah.
For sure. You know, sometimes when I'm in gatherings, side note for sure.
Yeah.
And people will start talking about like women. They'll start talking about stuff. Right?
And you jump in there.
And I say, you know, I believe this is what you should do. And then they all look at me and say,
Like,
why are you speaking? And I said, well, I run a fertility show. With a doctor.
you got a video of that one. I want to see that sometime.
It happens often.
That would
believe
be
it or not.
priceless.
Because some of the questions in circles,
Right. You're there.
I'm there.
You know the answer.
I know the answers.
We got to take some YouTube questions.
Yeah, they're blowing up.
I see them here. You want me
Yeah.
to take one from here?
Oh yeah, you see them there. That's right. Go ahead.
Hi T.
Oh, it just gets better and better.
And then it says Doc. Like I didn't get a hi. You got the hi. I just get the dog. Several IVF cycles with lining no more than 5 millimeters. Did cycle day 14 scan while med-free, hoping for improvement, but lining was 3.5 millimeters. Ugh. What's wrong with me? Have you ever dealt with such a thin lining? That's from Sarah V. Yes, I have.
I haven't.
You haven't, yeah. Okay. So I have dealt with thin linings, and I have dealt with them that thin. So there's lots of stuff you can try first. Number one would be the ultrasound, like an SIS, to see if there's something wrong with the lining. Number two would be to see if there's infection in the lining, like with the Fertility test that we do, or Emma analysis. And then aspirin, vitamin C, D, and E can all help. Viagra, you can do Neupogen, you can do human growth hormone, you can do PRP. All of those have also been shown to be beneficial. So those are all the various things we try in order to thicken the lining. If all of that fails, it is the one exception I make to telling everyone the ERA test is useless, because it is useless, but it can tell you if you're at least receptive. Don't trust the timing of it at all. It's useless. But if it at least shows that your proteins and enzymes and everything are in the right phase, at least you'll know that your lining has the capacity to support a embryo. And I will tell you that one of my most difficult patients ever, I could not get her lining more than 5 millimeters. She refused the surrogate. We did the ERA test. It came back positive, saying she was receptive. So we transferred the embryo and it worked. So she had her baby. She had one embryo and that was it. So I had to make sure it was perfect. And that same patient is asking, she will also do an Emma and an Alice during a mock cycle next month. How does Emma differ from other microbiome tests? It doesn't. It's not as complete as the one from Fertility, but it's decent. Your turn.
Okay. Instagram.
Yeah.
Hi, Dr. VNT. H35, 3 embryos from 2 retrievals, 1 cc, 4 BC, 4 cc. Would you recommend PGT?
Well, it's too late now. And the study we reviewed last month suggests that you shouldn't. The problem with those embryos is they're not great quality, unfortunately. So that would be tough. What was the first one?
1 cc.
1 cc. Yeah, those are not great embryos. Oh man, that's tough. It depends on how much you have to pay for your embryo transfers and if they did already biopsy them or not. If they didn't already biopsy them, I would definitely never thaw those embryos for biopsy because they probably won't survive the thaw, biopsy, refreeze, rethaw. If they have already done it, and the question is, should they have done it? My answer probably would have been no. I would have gone ahead with the transfers if your embryo transfers are reasonably inexpensive. If they're pricey, then yeah, I probably would have done it to reduce the chances you're transferring abnormal embryos. It's a tough question.
Tough question,
Good
yeah.
one. That's a really good one.
Hi, Dr. V. This is just for you, sir. Do you
I deserve one every once
know
in a
what?
while. Yeah.
I think you deserve a couple for sure.
Okay.
Do you think
Yeah.
2 months of Lupron Depot would be enough for failed implantation? Doctor doesn't suspect endometriosis.
If you don't think you have endo, then I guess I'd ask why you're on the Lupron. But sure, I mean, 2 months would probably be pretty close to enough. Yep.
Hi, Dr. V&T. How do you adopt an embryo in Ontario? I can't find a lot of information online about it. Thanks.
You just have to go to each individual center and say, I'm here for embryo adoption. What do you guys have? And if you are next in line and they have what you want, you adopt the embryos. No one's allowed to sell you the embryo, so never pay for anything other than the cost of maintaining the embryo and the embryo transfer, and that's it. So it's really cheap compared to doing IVF usually.
Interesting question. Ready?
Yep.
From the Dominican Republic.
Oh, cool.
Absolutely cool.
Hey,
In your opinion,
save me a spot on the beach.
Oh, too spots. In your opinion, is it possible to do a genetic test to a group of 6 frozen embryos, and do you think could be any damage? There could be any damage.
Yeah, so if they're already frozen, you need to thaw them, hope that they expand, biopsy it, refreeze it, and then rethaw it again. Depending on who you talk to, some people will say this is terrible, and other people will say that it's perfectly fine. I can't see how it's perfectly fine, but I know that the genetics coordinator, captain in chief at Create swears by it. She says it's not a problem at all. They've done it up to 4 times. I just don't see how an embryo survives that easily. So embryos are not designed to be frozen to begin with. So the fact that we can get away with it once is amazing. The concept of doing it multiple times, I don't know, I'm not there yet. So I would avoid it if you can. If you have to do it for some reason, sure, then do it. But if you don't have to, I would avoid it if I were you. Probably do more harm than good, especially if it's not being done at a top-notch center.
What do you think of intralipid therapy after 3 failed transfers?
After 3 failed transfers, I think just choosing intralipids therapy is naive. You need a full workup. We need to figure out what's wrong. Somebody needs to take a look at everything that they've done for you, determine if it's infection, thrombophilia, sperm quality, egg quality, embryo quality, genetics, problems with infection, problems with immune system. You can't just say, okay, I'm just going to try intralipids. We're way past that era of medicine now. So you need more than that.
I'm more than 12 weeks pregnant
Congrats.
and have very bad nausea and vomiting.
Oh, sorry.
I'm taking
So
Zofran,
yeah.
only meds that help me. Is it safe for the baby?
It depends. As long as you're not vomiting all the time, it's okay. It's not good if you're vomiting everything and you have no energy level. Zofran's safe to the best of our knowledge. You should be taking diclectin 2 pills 3 times a day because that helps keep the nausea away as well. Gravol is also safe. So any of those would be reasonable choices.
How much is a normal amount for 1 round of IVF?
A normal amount of what?
I don't know.
Cost or eggs or? Yeah, I don't know what you're asking, dear. So it would depend on whether you're asking about eggs or the cost of the IVF or whatever. I don't know. Normal IVF cost probably about 11. Normal number of eggs, so dependent on your age, but let's say average 8, 6 to 8. I guess that's it. How many embryos? 3 or 4 on average, somewhere in there. I still have, did you get any Facebook ones? There's a Facebook one
Go
here.
for it.
Dr. V, I have a procedure coming up with you and I am very nervous. My husband's sperm count is still very low. Is there still a possibility for us? Yes, there's a great possibility for you. As long as we can get some sperm, we don't need a ton, we just need a few. Jenna Marie, has Lupron Depot been found to possibly cause a thinner endometrial lining? I did an FET prep and it got canceled after a long time on lots of estrace with no luck, and then took about 45 days to get my lining to 8 with my second FET on oral, vaginal, and transdermal estrace, 4 Viagra suppositories. Now I'm doing natural cycle FET, good job, and my lining is fine. Yeah, I mean, if you take Lupron Depot, it's going to suppress everything, so you would need a lot of estrogen to wake it up again. So it was definitely the Lupron. Hello, thoughts on Visage?
Vizan.
I think they meant Vizan.
Yeah.
Versus Mirena IUD for adenomyosis. Can adenomyosis go through laparoscopic surgery? You can remove adenomyomas from laparoscopic surgery. They're very difficult to deal with, so I don't recommend that. And then as far as Vizan versus the Mirena, the Vizan is definitely more potent than the Mirena is. Yeah. Hi, Dr. V and T. Would you recommend inositol for a woman with endo to improve egg quality? Is it only beneficial for women with PCOS? I have not seen anything that says inositol is helpful for endo. NAC, coenzyme Q10, resveratrol, and curcumin are beneficial for endometriosis. I haven't seen anything on NAC. I'll do one more.
Go for it.
Lupron and Orilissa, do they ease pelvic pain associated with adenomyosis or reduce the implants in the myometrium? They do both. So they'll help you with both of those. Your turn.
Hi, Dr. VNT. Can you discuss the level of research behind PRP into ovaries to try and improve egg quality?
Yeah, I can. It sucks. So there is only one decent study, and that one study showed a very small chance of success. All the other studies were garbage, you know, that don't even justify publication, to be honest. So there's one study, a reasonable number of people. They showed like an overall, I think it was 13% live birth rate in people that had very poor chances. One of the major authors is Richard Scott. I asked him privately about it. He said he doesn't know yet, but it seems promising. So the research is not there yet.
How many days past trigger for IUI can I take a pregnancy test? My doc said there to take one 12 days, but doesn't trigger stay in your system up to 14 days.
No, the trigger should be out of your system by 5 days. So yeah, you could do it as early as like 8 or 9 days if you're doing a home test with one of the early predictor tests. More like 12 days if you want to be reasonable about it.
Do you think Neupogen or HCG wash is useful for implantation failure patients?
I think we asked that one. Yeah, I do.
I'm more than 12 weeks pregnant. Oh, we did that.
We did that one too.
Yeah. Is 200 milligrams of vaginal progesterone a day enough post-IUI with an endometrium lining of 9.8?
Say that again?
Is 200 milligram vaginal progesterone a day enough post-IUI with an endometrium lining of 9.8?
No, you should be doing 200 milligrams 3 times a day until 12 weeks and then drop down to 100 3 times a day for the rest of the pregnancy pretty much.
Is 5 million washed sperm enough to yield a pregnancy in IUI?
No. So we've got 2 videos on this. One said 9 million, one said 14 million. 5 million would be below the threshold. So you're looking at somewhere around the 3% chance of success. So there is a chance, but it's low. Let me answer one here. First of all, from Sonoz, which is a Persian name, so very cool. Thank you for watching, Sonoz. You guys make the topics fun to follow. Thank you. That's sweet. I like that. Thank you, Sonoz. Okay, and from Sarah V. Dr. V, I want to make an appointment with you, and the website directed me to fill out a form. Will someone be calling me to schedule, or can I call directly? You can call directly, 519-944-6400. If somebody doesn't answer, because we are super busy, leave a message. Someone will get back to you. or just email info@drvictory.com, drvictory.com. The new website is coming. Are we almost there?
Stunning.
Is it?
Stunning.
Excellent.
Thanks for all your help, Dr. Reed. Our twin boys are due at the end of the month.
Oh, awesome. Congratulations. Glad it worked.
Had first ultrasound at 6 weeks, 5 days. Baby was measuring on track and heartbeat was seen.
Okay.
I have my second one tomorrow at 9 weeks, 6 days.
Sure.
Tips for easing anxiety. I haven't had spotting, but I don't have many symptoms.
Do things you love to do. Read a book if you like to read. Go for a walk if you like to go for a walk. Watch a movie. Pray, meditate, yoga, like whatever you enjoy, do whatever you enjoy. That's what's most important during the crunch times. And, we have a great video with Dr. Sen, which I wish more people would watch. She's brilliant. And one of the things she says is, it's actually okay to be super happy and be super terrified at the same time. People always expect that once you're pregnant as a fertility patient, you should just be happy. But the reality is, you're happy, of course you are, but you're also terrified because you've gone through so much trauma to get to that point, and you're just waiting for the shoe to drop. So it's okay. Like, you have to acknowledge the fact that it's okay. You need to accept yourself as being someone that's happy and anxious at the same time. It's not a paradox. They can cohabitate, and that's okay. You just have to accept it, and that'll help you deal with it as you move forward. Find, as she says, a safe space where you feel comfortable being nervous, but you can also be happy for what you're going through, and stay in the happy space.
Do you know if Life Labs will draw blood for fertility test tubes to send back, or
No.
do we have to come to Sarnia for this blood test?
Yeah, I would go to Sarnia, Life Lab. Well, actually, I shouldn't say that. They might. Ask the girls about that in the office. I'm not sure if Life Labs does or not, but they might. Because I know we've sent patients to other places before to do it.
Hello, Dr. Victory. Regards from the Dominican Republic.
Again.
Yeah, different person.
Dominican, man. I love it.
This
Hey,
is great. In your opinion,
we're popular everywhere.
I'm
Yeah.
feeling the beach. Is it possible to do a genetic test to a group of 6 frozen embryos, and you think...
She asked us that.
She asked you that. We said that.
Same
Yeah.
patient.
Yeah. What can affect uterus lining not growing more than 6 using estrogen, intramuscular, and vaginal?
Infection, scarring, previous damage, previous surgery, wrong protocol for you, obesity, hyperandrogenism. There's all sorts of reasons that could be doing it.
Last question on Instagram.
Okay. Wow, we actually got through them all.
Kind of, yeah.
Okay.
What are the best supplements to take prior to an FET, and how long should you take them prior to the procedure?
Vitamin D, melatonin, aspirin, iron, B12, omega-3 fatty acids, and your prenatal, and start them like a month before.
Dr. Sen is the best. Please bring her back.
Oh, really?
That's what Tom says.
Oh. I was checking out the video on YouTube. There were only like 370 views or something. Make more people watch that. We'll bring her back. In what conditions would you recommend the Lupron or Alyssa versus the Vizan? So Lupron sucks for side effects. So if someone was really worried about the side effects or sensitive to it, then the Orilissa. Orilissa is way milder in side effects and probably second best. However, there's no data to support using Orilissa before an FET. Vizan there is. So then I normally turn to the Vizan. Done? End the show. All right, guys. Well, thank you for joining us. Sorry for the sound glitches. I did select the right one, but it kept glitching. So hopefully you're able to hear us. And we will be back, I think, next week. Next week we're back, right? Next week we'll be back on Tuesday night for another Fertility Factor Fiction. Remember, if you are doing your own research online, only do it if you trust the website you're at, and preferably take it to your doctor and have them analyze it. Because I got a paper from a patient today that said that growth hormone causes cancer, but it was treatment when they were kids who needed growth hormone. Completely different from taking it for 2 weeks when you're doing an egg retrieval. So make sure you're dealing with apples to apples and oranges to oranges. Have a great night. We'll see you again next week on Fertility Fact or Fiction. Bye, guys.